the beginning of Part 2, the Foundations of Breastfeeding Knowledge. The objective of providing informed choice for the breastfeeding decision, the physiology of lactation, the medical contraindications to breastfeeding, and what is the risk of artificial feeding for babies. So let's talk for a minute about promotion. Well, the healthcare provider's role in breastfeeding care, part of that is the appropriate approach as far as promotion is concerned. Once again, the care practices that we have in protection, and then the support that we have should be knowledgeable and skilled. So, does promotion work? Well, there was a study done and published in 2001 in Obstetrics and Gynecology that showed, and this study was a nationwide survey, that when women had healthcare providers recommending breastfeeding to them for all of the mothers in the sample, when they just did a complete look at all of the mothers in the sample, mothers were 4 times more likely to breastfeed if their healthcare provider recommended that they do so. When they broke it down into individual groups, they found that young, low-income women that were less educated were 3 times more likely to breastfeed if their healthcare provider recommended it. They saw a nearly 5-fold increase among black women if their healthcare provider recommended that they breastfeed. And then there was a nearly 11-fold increase among single women. And the low-income, less educated black women and single women, those 3 groups are the groups that were less likely to breastfeed, so they were very much impacted by promotion efforts. So even when moms are given that promotion effort, even when they are given information on breastfeeding and given the opportunity to choose that, why do some women still choose not to breastfeed even after given that information? Well, in considering their options, what they look at is they weigh breastfeeding and formula feeding. Which one is more important? Are they equal? Is breastfeeding just kind of like taking a vitamin, but formula feeding is really great too? And that's what they are weighing when they weigh whether or not they should breastfeed or formula feed their infant. They are also weighing breastfeeding against their barriers. Here are my barriers to breastfeeding. I'm going back to work. Is breastfeeding worth the effort? When my barrier is going back to work, when I know that I'm going to have to return to work at 6 weeks, should I go ahead and choose to breastfeed? Is my barrier too large to overcome with that? So as far as that first one, the belief of importance, the belief or the value that they place on formula feeding versus breastfeeding, there are huge cultural messages out there that say that formula feeding is a value, that formula feeding is something that in our culture is considered normal. It is considered a cultural norm. One of the reasons is that they see babies being formula fed, but they don't see babies being breastfed. As a culture, we are not comfortable with the sight of women breastfeeding their babies in public. And our mother support groups have really enlightened us on that barrier, really have enlightened us on how they have been, some of the responses that they have gotten when they have breastfed in public. Even when they've breastfed very discreetly in public, people still in the United States have a hard time dealing with the thought of a woman breastfeeding her baby. We had a mother just a couple of years ago that was in a restaurant breastfeeding her baby underneath a blanket. She had the blanket over the baby and she was breastfeeding the baby under there, and the waiter in the restaurant came up to her and said, "Are you breastfeeding your baby under that blanket?" And the mother said, "Yes, I am." And the waiter said, "Well, the people at this table over here are offended by that, and we were just wondering if you could move to another table, maybe in the back of the restaurant." And so that was the response that she got from not exposing anything at all, but just from the thought of her breastfeeding her baby. The people at the table next to her were offended by that, and offended enough that they spoke to the waiter, and the waiter felt it necessary to take that message to the mother. So that belief of importance and looking at formula feeding as being more of the cultural norm is a huge message to mother. Sometimes we even contribute to it by being, healthcare providers will contribute to that. Sometimes we will accept things from formula company reps, such as wearing formula company logos on the badge holders that we have. When we have a badge holder that clips our badge to our uniform or to our scrubs, A lot of times formula companies will give out those kinds of badge pools, but it will very subtly have their name on it, so that mothers will look at that healthcare provider and they will see the name of that formula company. And that sends a subtle message that that healthcare provider is endorsing that product. Sometimes some offices will use formula handouts to educate mothers. Formula companies will produce handouts for education purposes, but on those handouts are their logo and their product, and perhaps even advertising of their product. And so when the healthcare provider hands that out, they are contributing to that belief that formula is a cultural norm. And then sometimes healthcare providers will actively encourage mothers to solve their breastfeeding problems by using formula, but they will not follow up with trying to solve the breastfeeding problem. If a baby is not gaining weight well, we'll start adding in formula and your baby will start gaining weight. And that is very true. If mothers supplement with formula and their baby's having a weight gain issue, yes, their baby, if done appropriately, should start gaining weight. Does it stop there? Is the breastfeeding problem addressed at that point in time to try and look at why that mother and baby are not able to exchange enough milk from mom to baby for the baby to gain weight? And then in considering the barriers versus breastfeeding, when a mom is looking at whether or not to choose to breastfeed as her method of feeding for her baby, here are some of the barriers that moms will talk about. They're embarrassed about breastfeeding. Nobody in their family's ever done it before, and they're just feeling really uncomfortable about that function of their body. Or they might have a negative perception of breastfeeding. Maybe they've had some friends that have, quote, tried to breastfeed and it was not successful for them. And so the stories that they hear are stories from people who did not have a good experience with it. Maybe they have a lack of support from their partner or from their family members about breastfeeding. Once again, if nobody in the family has ever breastfed, then they might not be that supportive of the mom. And then other family responsibilities, the need to return to work, the need to go back to school. And then some mothers perceive that this might cause a decrease in the ability of the father and the child to bond together, and that's very important for some women. They feel like this might be a way to attach the father to the child, and so therefore that will attach the father to them also. And so that can be a barrier for that mother. Well, the healthcare provider needs to avoid conveying the message that formula feeding and breastfeeding is equal, or that formula feeding for that mom might even be better. And they also need to convey the message that the value of breastfeeding outweighs the barriers that she faces. So that's our role in promotion. It's not just to give a mom a list of the things that breastfeeding prevents. Your baby will have fewer ear infections if you breastfeed. Your baby will be less likely to develop diarrhea. Your baby will be less likely to have upper respiratory infections. Those are great things to talk about, but that might not be the main thing on that mother's mind. And so this is actually the healthcare provider role, is to convey the message that breastfeeding is normal and breastfeeding is better than, and then also to convey the message that breastfeeding does outweigh the barriers that she faces. And the way to do that is to be ready to identify and address the barriers to breastfeeding. So how do you do that? Well, the best way is to ask an open-ended question. I recommend breastfeeding is the best choice for moms and babies, and that's the opening statement, and then to ask one of these three questions. Tell me what you know about breastfeeding. Or what are your concerns about breastfeeding? Or do you have any questions regarding breastfeeding? The very next thing that mother says is going to be her barrier. She's going to tell you what her concerns are, or she's going to tell you what her barrier is when you ask that kind of open-ended question. Once she identifies that barrier, then you can respond to that barrier. And maybe it's something like a 17-year-old who's in your practice who has decided that yes, indeed, they are going to keep their baby. You know, it might be an unmarried mother, and she has decided that she is going to keep this baby, and you're talking to her about, I recommend breastfeeding is better for moms and babies. Tell me what you know about breastfeeding. She might lean back and say, well, I know it ruins your body. And she's a 16-year-old or a 17-year-old, and to her, that's an important barrier. And so that's a time for you to respond to that barrier rather than hand her a pamphlet on your baby's going to have fewer ear infections. At that point, while she is pregnant, being 16 or 17-year-old, the most important person in her world is herself. That's who she focuses on, is herself. She doesn't know at this point in time how much she's going to love this baby. And she doesn't know what it's like to have a baby with an ear infection. She doesn't know all of those things. But she knows what her barrier is to breastfeeding, and this gives you the opportunity to respond to that. So let's talk a little bit about the physiology of lactation, because just knowing the basics of the physiology helps you to answer some of the questions that you might have from moms when they come into your office. So we're going to go over just breast anatomy. First of all, nipples and areola come in all shapes and sizes. And the old wives' tale, or the old advice that used to be given all the time about get the entire areola into the baby's mouth and you'll know that the baby's latched on well. Well, take a look on this picture of this areola and look at that baby's mouth. And imagine that baby trying to get that entire areola in its mouth. That's very poor information to give moms on breastfeeding. So we need to know that breasts come in all shapes and sizes, and that every baby and every mom's individual as far as instructions and help that's given on appropriate latch-on. The glandular tissue that's in the breast makes and transports milk, and there are some of the structures there listed right there. The lobe of every mammary gland consists of a single branch of alveoli and milk ducts, and in the back, that alveoli, the alveoli cells, that grape-like cluster in the back of the breast tissue, that's what actually makes the milk, and then it goes into the milk ducts and goes down that main milk ducts and travels to the nipple, and there are pores that open up from the nipple that the milk actually comes from. Breast size is not a determinant of how much milk a mother will make, and that's part of the breast anatomy, is how much fatty tissue is in that breast, the connective tissue that is stored fat. Well, that fatty tissue does protect the breast from injury, but it is not what tells us how much milk a mother will make. Breast size does not have an effect on the amount of milk or the quality of milk that a mother makes in a 24-hour period. And that breast will usually enlarge during pregnancy is another important piece of information, but not always. So if a mother says to you later in her pregnancy, well, I just haven't had that much size increase, I don't know if I'm going to be able to make milk. It does happen most of the time, but it is not something that absolutely tells us this mother's not going to make adequate amounts of milk. Some of the hormones that are involved in lactation are estrogen, progesterone, prolactin, oxytocin, insulin. But what we're going to focus on right now is the prolactin and oxytocin. Prolactin is what causes milk production to occur. And in order for prolactin to work, there have to be specific receptors present in the breast. Thus, just prolactin levels can be misleading. You can take a woman's prolactin level and you'll find out that there are surges in prolactin levels, that when a baby latches on and breastfeed, her prolactin levels will go up temporarily and then they'll go back down again, those surges. And what we know about prolactin receptors is that those surges over baseline in the early days of breastfeeding is what lays down the prolactin receptors. We also know that that response is delayed in overweight or obese women. And so that knowledge of prolactin tells us why mothers need to breastfeed frequently in the early days of breastfeeding. Because you've got to have several surges over baseline of prolactin levels in order for prolactin levels to be laid down, in order for the breast to pick up the prolactin so that milk can be made. And so that explains the early need for frequent feedings. Prolactin is also high the first 2 hours after birth and at night. So that explains why an early feeding is important. If you're going to have a huge surge in prolactin levels during the first 2 hours following delivery, you're going to lay down several prolactin receptors during that time. And then how many times have pediatricians or nurses or obstetricians gone into mother's room and the mother has said, my baby was up several times last night feeding, when they're still there in the hospital? Well, nature provided that for us so that the prolactin levels, which are naturally higher at night, will also surge more at night, laying down more prolactin receptors so that the mother will have the capacity to pick up that prolactin in the breast and therefore produce adequate amounts of milk. Oxytocin is the letdown hormone, and that hormone causes the contraction of smooth muscle layer of some band-like cells that surround the alveoli, and that squeezes milk into the duct system, making milk available for the baby. So sometimes the infant swallowing can be the only indication of letdown that a mom has. Many times she'll feel some other sensations, but sometimes she'll just, in the beginning, start to hear that letdown occur because she'll hear a few swallows in the first few days. About every 5 to 10 sucks is what you can usually look for in the first 24 hours, and then it will increase after that. Lactogenesis 1, 2, and 3 is involved in milk production. And lactogenesis 1 is the development during pregnancy of the mammary gland's capacity to synthesize milk. It's present in the breast at 17 weeks. And so when a mom says to someone coming into her room after she has delivered, I don't feel like I'm making any milk, and it's in the first 24 hours following delivery, she's got something that was present and was being produced at 17 weeks. Colostrum is very specific to the infant's gestational age too, so if a mother delivers at 30 weeks, her colostrum is specific to a baby that's 30 weeks, and it has the components that are important for a baby at that gestational age to get. A mother with a 34-weeker, her colostrum is specific to a 34-week gestation baby. And then all mothers, when they deliver their babies anytime after 17 weeks, they have something that was designed for their baby right there at that point in time. Here's what colostrum looks like. If you want to see the perfect colostrum, there it is. It'll be kind of a clear color. It will look a little bit thicker, if you want to use that phrase, than milk. It won't look quite as thin as mature milk looks. It's very easily digested by the baby, and it has a gentle laxative effect on the baby, so it helps that baby get rid of that meconium. It can also be a cause of causing that baby to be fussy and to cluster feed. Now, you already know why it's important for a baby to cluster feed in the first 2 or 3 days following delivery, because it will cause surges of prolactin. The more frequently a baby feeds, the more prolactin surges that mother will have, the more receptors she'll lay down, the better her milk supply will be. And so cluster feeding is designed for babies, and colostrum is part of that cluster feeding taking place. So it's very important to know that and to share that with moms when they say, oh, we fed a lot during the night last night, or he's fed every 2 to 3 hours during the day today. You can turn it around from a negative, which is, oh, I'm so sorry you're tired, to, gosh, there's a reason for that. Let me explain it to you. One of the ways that we identify good babies in our culture is how often does a baby feed. And so one of the things that we want to avoid saying to moms is he a good baby? How often is he feeding? Or when she says, oh, he's only feeding every 4 hours, well, he's a good baby then. Because a baby feeding more often is not a bad baby. He's actually in the first several days doing exactly what he's designed to do so that he can help mom's milk come in well. Colostrum is also very rich in antibodies and immune properties. It coats the lining of the intestines. It protects against swallowed bacteria and viruses, and those things are just absolutely essential for new babies. When you walk into a mom's room and a baby has spit up a little bit of colostrum and you see it there on the, like if the baby is laying in the bed and you see it there on the blanket next to the baby, and she says, oh, I'm not sure that, it's my colostrum is agreeing with him or my milk is agreeing with him. He's spitting up a little bit. Spitting up is a normal thing, and most babies do spit some. And when a baby spits that colostrum, it will coat the inside of the baby's mouth. It will go up into the eustachian tubes, and it will also go up into the nares, and it will actually stop viruses and bacteria on contact. They can't even gain entrance into the baby because of that colostrum being there to coat that. And that's what spitting up is designed for. So you can turn a negative into a positive when you just have some basic physiology behind what you know about milk and milk production. Lactogenesis 2 is that time that we talk about when mother's milk comes in. Now, there is no time where mother does not have milk and then suddenly mother has milk. Lactogenesis 2 is a time that milk starts to be produced in larger and larger quantities, but remember, she had colostrum, which is a form of milk there from the time she was 17 weeks pregnant. So I wish that we hadn't phrased it as mother's milk coming in, because it leads mothers to believe that their milk is not there to begin with. But anyway, Lactogenesis II is endocrine controlled. It's programmed by hormonal changes that the mother goes through. And when she goes through those hormonal changes, even if she does not breastfeed her baby, more than likely she is going to have some milk to come in. It might not be in the quantities that she would have had if she had breastfed in the first 2 or 3 days following delivery, but she will probably get milk to come in. When that milk comes in, it's going to be accompanied by a feeling of fullness and warmth in the breast, and it might also be accompanied by a low-grade temp. And so it's important for your staff to know if a mother calls in on the 3rd day, she's gone home from the hospital, she's no longer with the nurses in the hospital, her milk comes in, and she's running a temperature of 99.8 or 100, 100.1, then that mom might call into your office and say, I'm running a temperature. Do you think it's okay if I breastfeed my baby? And that practitioner, that person talking to her, knows that this baby is only 2 days old or 3 days old, then they can give her the appropriate information that, gosh, if it's only 100, if you're running a low-grade temp and your milk is coming in, this is a normal occurrence with your milk coming in. So that she's not at home worrying about whether or not she's coming down with something or she's going to give something to her baby. So just that basic knowledge about Lactogenesis II is very, very important for your staff to have. Milk volumes are also something that's essential for all healthcare providers that deal with mothers in these early days to have information on. And milk volume in the first 36 hours is only going to be around 50 cc's per 24 hours. Well, the nice thing about that is, guess what the baby's stomach capacity is? The baby's stomach capacity in the first 24 hours following delivery is only about 10, maybe 12 cc's in a 24-hour period, not a 24-hour period, I'm sorry, 10 or 12 cc's per feeding time. That's how much their stomach can comfortably hold during that time. So the amount of colostrum that a mother makes for a feeding is very appropriate to her infant's stomach capacity. As her volume starts to climb, by day 4 through day 10, she's rapidly going to climb to about 500 cc's per 24 hours. And then between day 10 to day 14, she's going to climb further to about 750 cc's per 24-hour period. So there's a huge change that takes place in that first 2 weeks. This is what a baby's tummy looks like as a newborn. At birth, the baby's stomach can comfortably digest what would fit into about a hazelnut, about 1 to 2 teaspoons. In the first week, a baby's stomach grows to hold almost the size of 2 ounces, or what would fit into a walnut. And so giving moms that explanation that your baby's tummy in the first few days, you don't feel like you have a lot of milk, but guess what? You should have exactly what your baby needs, because your baby's tummy has not started expanding yet and relaxing yet to be able to accept more milk. But by the time your milk's coming in really well, your baby's stomach is going to be able to hold that. Lactogenesis III, that 10 to 14 days postpartum, is autocon controlled. That's the maintenance of established secretion. We have gotten up to that 750 cc's per 24 hours, and now Lactogenesis III is the process by which we maintain that milk. And what autocon controlled means is, when you remove, it's replaced. When you remove, it's replaced. When you remove, it's replaced. So the more often the milk is removed, the more often it will be replaced. And that's the way to increase or decrease milk supply. The more often you remove, the more milk the mother will make. The less often she removes, the less milk she's going to make after a period of time. So she needs to be consistent with her removal. If she is a mother who has a baby in the intensive care unit, she needs to get up to the 750 cc volume, because that's the normal volume that will allow her to maintain her secretion of milk. If she falls down below that volume in a 24-hour period, if she is less than 350 cc's per 24 hours for over 5 days in a row, then her body is going to start changing the way it produces milk, and that mother is not going to be able to get back up to the volume that her baby will need as it grows. And so it's important to be consistent with removal Even though babies are not taking 750 cc's while they're in the intensive care unit and they're these small preemies, that's the target that she needs to get to, and then to continue to remove that milk on a frequent basis so that she can maintain that volume and have that milk for her baby once that baby is able to take that volume of milk. When the mature milk comes in, it's going to be wider, it's going to be thinner, and the fat's going to separate on standing. We have had this call before, moms to call in and say, there's a film on the top of my milk and I think my milk is spoiled, when what that actually is the fat separating. Mothers are not used to seeing non-homogenized milk. We live in a culture that we don't drink raw cow's milk anymore. We drink milk that comes from the grocery store. And so their normal viewpoint of milk is that milk is homogenized, that the fat does not separate. But with human milk, it's not homogenized, and the fat is going to separate on standing, and all they have to do is just gently shake that bottle and mix that fat back up again before they feed. Another call that we have sometimes is about the color of milk, and while it is normally kind of a whitish color, maybe with a blue tinge to it, you will also see moms who eat a lot of leafy green vegetables having a green color to their milk. It will just be a faint green color. Or if a mother takes prenatal vitamins, many times those prenatal vitamins will cause her to have kind of a greenish tint to her milk, and that is perfectly normal. There's nothing wrong with that at all. When you know about milk and what the milk is made of, you know that 87.5% of milk is water. And that's the explanation behind why babies don't need water when they are breastfeeding. For the first 6 months, even in hot environments, babies do not need additional water on top of breastfeeding. They are on a liquid diet, and the amount of water in the milk is going to provide for them the water that they need. So what are the risks of artificial feeding? We've talked a little bit about the anatomy and physiology of breast milk. Let's talk about why it's not okay to supplement, why it's not okay to give babies something else besides mom's own milk. Well, we know that the American Academy of Pediatrics recommends exclusive breastfeeding for about 6 months, with a continuation of breastfeeding for 1 year or longer as mutually desired by the mother and the infant. The literature supports that recommendation, and there's a wonderful report out that was done by the Evidence-Based Practice Centers of the Agency for Healthcare Research and Quality through the U.S. Department of Human Health Services. They prepared a report that gave us a comprehensive look at the literature and analyzed the scientific literature that compares breastfeeding with formula feeding and the health outcomes that are involved with that. So the risk of not being breastfed are numerous. There are short-term risks. A baby who is breastfed for at least 3 months or longer, that baby is at a 50% lower risk of having ear infections. For 6 months or longer, that baby is at a 63% less risk for having upper respiratory infections. Greater than or equal to 6 months, 77% lower risk of lower respiratory infections. During the intensive care unit, the incidence of NEC is 77% less. Of gastroenteritis, for any breastfeeding at all, there's a 64% lower risk of developing gastroenteritis for any amount of breastfeeding. As far as longer-term risks are concerned, for any breastfeeding at all, there's a 24% lower risk of obesity at age 6. For type 1 diabetes, for greater than 3 months, 30% less risk of developing type 1 diabetes. For type 2, with any breastfeeding, there's a 40% less risk of developing type 2 diabetes. For leukemia, ALL, greater than 6 months, there's a 20% less chance of that child developing that childhood leukemia. For AML leukemia, for greater than 6 months of breastfeeding, there's a 15% reduction in leukemia in that population. And then any breastfeeding greater than a month, there's a 36% less risk of SIDS for that infant. So the risk of not being breastfed are very much in the literature, and they're very, very real. Another risk of supplementation has to do with allergies. With a negative family history, if a baby is exclusively breastfed for greater than 3 months, even if there's no family history of allergies, that baby is at a 27% lower risk of developing an allergy. With a positive family history, there's a 42% lower risk if that baby is exclusively breastfed for greater than 3 months. So allergies also play into those risks. So, okay, you know, we understand the risk of not being fed breast milk. Well, how about how we feed babies something else? The use of supplements or pacifiers in the hospital is associated with a risk for early weaning. So it's our responsibility to encourage parents to avoid the use of pacifiers, artificial nipples, supplements, unless there's a medical indication for it and until breastfeeding is established. So even mothers who come to us and say, I want a breast and bottle feed, we can very definitely help them do that, but we do need to let them know the risk of feeding something other than breast milk. And we also need to let them know that in the beginning, if they use pacifiers or supplement with a bottle in the hospital, that their baby is at higher risk for early weaning. So it's important that they get breastfeeding established, which usually takes around 3 to 4 weeks before they start using something else. So 3 to 4 weeks, and then it's only if they really want to use an artificial nipple, because some babies never use artificial nipples. Healthcare providers used to say to parents, well, you need to teach your baby to take a bottle, and that's really not true, because some mothers never choose to give their babies bottles. And, quote, teaching their baby to use a bottle early on is not a guarantee that 2 or 3 months down the road the baby's not going to reject the bottle, because our babies are pretty smart, and they know what they like to do. And I don't believe in nipple confusion, but I very definitely believe in nipple preference. And babies can have a preference for the type of nipple that they have. And the sooner they are introduced to a bottle nipple, the more likely they are to prefer that nipple over mom's nipple, because they have to do less work to get that nipple into their mouth and to keep it in their mouth. What are the medical contraindications to breastfeeding? That's something that I feel we need to go over when we're talking about just some of the basic things about breastfeeding. Well, Ruth Lawrence, the author of Breastfeeding, A Guide for the Medical Profession, says, given the benefits of breastfeeding, are there really any contraindications? And there are contraindications, but they are very, very rare. And the reference that I used for this is the American Academy of Pediatric 2012 statement on breastfeeding and the use of human milk. As far as mom is concerned, being HIV positive, human T-cell leukemia virus type 1, having active tuberculosis, she can provide her express milk for that baby. She just should not be with that baby before treatment of at least 2 weeks, and it's documented that she is no longer positive for passing that infection to that baby. And then herpes, a lesion on or around the nipple. Untreated brucellosis is a contraindication for breastfeeding until that's been treated and cured. Moms who develop chickenpox 5 days before or 2 days after delivery should be separated from their baby, but they can provide milk for their baby. And then moms who are actively infected with H1N1 should be isolated from their infants, but they can provide milk for their baby. And as a matter of fact, the milk that they provide in that circumstance might be the very thing that helps that baby not get H1N1, because the antibodies that her body is developing will be in that milk that will be passed along to that baby. And then as far as maternal breast cancer is concerned, just for treatment purposes only, we actually have had a mother who came through who had breast cancer and had a mastectomy and was able to successfully breastfeed on the breast that she still had. And so breast cancer does not preclude a mom from breastfeeding unless she's in active treatment with medications that would cause that to be a contraindication. And then there are maternal medications, but they are relatively rare, and most of the time there are alternatives out there if the healthcare provider will look for those alternatives. And then as far as the infant is concerned, galactosemia is the only absolute medical infant contraindication to breastfeeding. PKU or other metabolic diseases, many times they can alternate breastfeeding with special protein-free or modified formula, provided that they are able to monitor that baby's blood, and that monitoring is available for that baby. And then what about alcohol? That's always a question that moms will ask, particularly at certain times of the year. Occasional and limited use of alcohol is not a contraindication to breastfeeding. In general, you should avoid breastfeeding for about 2 hours or 1 after 1 or 2 alcoholic drinks. And you really don't have to pump and discard that milk during that waiting time, because the milk that's in mom's breast is constantly changing. What's in there is being pulled out. When alcohol is leaving the mother's body, when it's being metabolized out of the mother's body, it's also being metabolized out of the mom's milk. It's called the milk plasma ratio. How much is in the plasma? If it goes down in the plasma, in general, it's going to go down in the milk. And then what about smoking? Should a mom be encouraged to cut down or quit smoking? Absolutely. But it's not a contraindication to breastfeeding if she does not stop smoking. If she cannot quit, she should be counseled to smoke after feeding her baby, not in the same room with her baby, to decrease the exposure that that baby has. And the evidence tells us that that's important, because moms who are smokers and bottle feed, and moms who are smokers and breastfeed, the moms who are smokers and breastfeed, those babies actually get fewer respiratory illnesses than the moms who were smokers and bottle feeding. So it is important for her to breastfeed. That is the end of part 2.